So welcome. We are recording this, and along with all of the other town halls, it will be on our CWLT website under the COVID link, and I will post that in a few minutes. This town hall is for information sharing purposes only. I only say that, so please no confidential case information. We do ask that, I ask that if you have any questions, I'll be monitoring the chat box, so feel free to put them in the chat box. Otherwise, you can type the words raise hand, and if you want to go off mute and ask the question that way, that works also. So in preparation, our next town hall is regarding what we've been seeing the last few months with school kicking back off. And that will be on November 5th, and that will be hosted by Yolanda Arredondo and Samantha Garrett. So I am very excited for our presenters today. I know we only have an hour to cover at least a week's worth of information, but we'll do our best. I will introduce all of our presenters and then our agenda, and then I will turn it over. So our the first person I'll introduce is John Lyons. He became the inaugural director of the Center for Innovation and Population Health at the University of Kentucky and a professor of health management and policy in the College of Public Health. After receiving a doctorate in clinical psychology and statistics from the University of Illinois, he spent 2 years under a National Service Award in mental health services research at the University of Chicago. His experience was followed by 24 years at Northwestern University, where he left as a professor in psychiatry and medicine and is the founding director of Mental Health Services and Policy Program. He was the endowed chair in youth mental health at the University of Ottawa and the Children's Hospital of Eastern Ontario, and then senior policy fellow at Chapin Hall at the University of Chicago. Dr. Lyons has more than 250 peer-reviewed publications and 6 books. His work focuses on comprehensive person-centered management strategies. Dr. Lyons' work has been and is currently implemented statewide systems in 41 states and on every continent except for Antarctica, and just give it time. Dr. April Fernando. So she is an Associate Director of Workforce Development at the Center for Innovation and Population Health, and Assistant Professor of Health, Behavior, and Society at the College of Public Health at the University of Kentucky. Dr. Fernando works with nonprofit agencies as well as child welfare and behavioral healthcare systems in implementing transformational collaborative outcomes management, or TCOM, utilizing the TCOM tools such as the CANS, the Child and Adolescent Needs and Strengths Assessment. She developed the CANS commercially sexually exploited version, which is used nationally. She's a licensed clinical psychologist, and Dr. Fernando brings her years of experience as an educator, clinician, and mental health administrator to her work with TCOMs and the CANS. We also have Dr. Andrew Gabor. He's an LPC and the Director of Children, Youth, and Family Behavioral Health for the Colorado Office of Behavioral Health. In this role, he oversees key funding sources for children and families who fall outside of typically publicly funded services and actively pursues policies and strategies to meet the behavioral health needs of all Coloradans. Andrew has been with the state for over 8 years and has previously provided therapy within community mental health centers, private practice, residential care, focusing on trauma and its impacts on children and families. And our last but definitely not least presenter, many of us know, Kit Thompson. She's a licensed clinical social worker and has been with the Family and Children's Services Director for Boulder, Colorado for the past 11 years. She's a member of the Family's First implementation team and has been the co-chair of the I-Team's assessment work group with Andrew and myself, has focused on the implementation of QRPT assessment process. So all of that to say, we'll have roughly 35 minutes for Dr. Lyons and Dr. Fernando to share and discuss the CANs. We'll then transition for roughly 10 to 15 minutes for Kit Thompson to discuss how we use the CANs in Colorado, and then Andrew Gabor to wrap us up in discussing the potential for how it can be used across all of our systems. And with that, I turn it over to Dr. Fernando and Dr. Lyons. Thank you all.
Thank you, Matt. So I think April's going to start.
You'll see a slide.
Yes.
All right. So actually, John Lyons, you are starting.
Okay. So, but you had to put up the slides. All right.
I did.
So we'll try and give you the elevator speech on what this is, but as Matt said, it's a bit of an onion, so it can unfold into quite a bit of complexity. But essentially, the concept of assessment, and we're not talking about measurement, we're not talking about anything, we're just talking about helping people. The concept is you meet somebody, and the first thing you want to do is you want to understand that person's story. So in a child welfare context, you meet a family, a young person, and you want to understand their story. And now, I don't know how many people at the town hall have kids. I've got kids, but I don't know if you've had the same experience I had, but my kids' story of their school was always a little bit different than the school story of my kids, right? And so you have these different storytellers, and this is particularly true in public sector work and child welfare and juvenile justice. You have different storytellers, and they're telling somewhat different stories about the same thing. So it's your job as a helper. So if you're charged with helping people, you need to take those multiple different stories and pull it into a single story, because you actually can't really be successful until you've got that story right. So you have to take these multiple storytellers, and that storyteller might be a medical assessment, it might be a psychological exam, I mean, it might be a neighbor's observations. There's all sorts of possible storytellers, but the job of good work is to take all those different stories and make one story. And although every story were different, if every story were different, there'd be nothing you could do. There'd be absolutely nothing we could do to help if every story was different. And so what you're doing is you're actually listening to the common themes of people's stories. And as you listen, you're looking for those common themes, because that helps guide how you think about helping. So you're listening, and you're listening to see if you've got a school-age child. Is there anything going on in school? Yeah, they got problems in school. Okay, well, what are the problems? Are they having problems going to school? Do they go, but then they don't behave? Are they going and behaving, but they're not learning? So you are looking for those common themes. So that's what basically what the CANS is a way of capturing those common themes. But it's done within a context, a theoretical context. So if I can have the next slide, April. Just go ahead and put them all up. So this comes from some economists that say, everything's a business. If somebody's getting paid, you're in a business. So the question is, what's your business? So it's organized by the easiest kind of business or commodities, raw material. You can take a commodity and produce something, making a product. We're not a commodity. We're not a product. Every now and then, people get treated like commodities. That's been the accusation of residential treatment of kids, right? But that's not good. People don't exist so that we're fully employed. That we're actually employed to help people. So we're not a commodities, we're not a product. We think about what we do as services, we talk about what we do as services, we organize and finance what we do as services, but the question then becomes, are we actually services? And the answer of that is no. A service is like a restaurant. So, and you think how a restaurant works, you get your space, you fill that space with tables. The job of restaurant management is to fill your caselets, your tables, right? So we structure our business as if it's spending time with people. We count the number of visits, we count a number of stuff, but that's not actually what our business is. So the next kind of business are experiences. That's when you're purchasing a memory. So you might have noticed that I spent some time in Ottawa, Canada. That's because I actually live in Ottawa, Canada. I still live in Ottawa, Canada, although I haven't lived there since COVID started, because I commute, and it's hard to commute. So I'm a landed immigrant, because it's the only way my wife and I can be together more than 240 days in a year. So I don't know if you know anything about Canadian immigration, but I'm forced by statute to mention hockey in every public experience. So if you go to a Avalanche game, what are you purchasing? You're purchasing an experience, right? A memory. So we're not in that, and we're not consumer satisfaction is not what we're about. So the final and the most difficult kind of business to manage are businesses in which the purpose of the business is helping people change their lives in some important way. So that's our business. So we have to learn, if we're going to be optimally effective, we have to learn how to manage our actual business, because we've been managing the wrong business, and that has been the fundamental corruption in the system. I'm not saying people are corrupt. I'm saying the system is designed to be fundamentally corrupting, because it's the wrong business. We're not a service industry. We're actually a transformational business. Now the next slide, please.
Sure.
Thank you. Oh, you go ahead and no, go ahead and put I like this. So fish, sushi, seafood restaurant, sport fishing, teaching people how to fish. So if you want the easy example of these types of businesses, so our business is teaching people how to fish. April is spectacular in graphics. So even if we don't work with you around cans and TCOM, you may want to work with her around, if you get PowerPoint envy. So anyway, now the other piece that's important to consider, and this is the follow-up from Pine and Gilmore, the economists who developed the hierarchy of offerings, is there's a great book, you might want to read it. It's called The Experience Economy that they published. And it talks about, it's mostly about experiences as a business, and their work is incredibly influential. I mean, you can't watch a commercial where it's not talking about trying to make things an experience, if it's a service or a product even sometimes. So, but their basic concept is you've got this, if you're going to have a transformational offering, if you're going to be successful helping people change, you have to start with a powerful personal experience. That's how you actually engage people. And so they talk about how do you actually create, in a business context, how do you actually create a powerful personal experience? So they say there's a continuum that goes from mass production to individualization. So if you have an intake process where this is the stuff we have to do and we have to do it in this way, that's mass production. So most public helping entities have that kind of mass production approach. Well, we need to do this. If you've ever been to the ER, it's like, well, we can't help you till we first find out if you can pay, and then second find out how we triage you and that kind of stuff, right? So that's mass production, right? That is thought to be not the way you engage people. It's off-putting, because if you think about it, let's take a step back and think about it from the side of the people who we're trying to help. Their experience could be captured as, I'm not saying this is how people say it, but this is how they experience it. We don't care about you until we first take care of our documentation, all that bullshit. Then we can take care of you once we take care of ourselves, right? So it's not exactly person-friendly, right? So the other extreme is individualization. That doesn't work either. This is kind of like the radical wraparound and recovery sort of folks, that everybody's different. You have to do something different for everybody. That doesn't work, right? Because, like I said before, you can't, if everybody were different, you'd learn nothing. There'd be no experience. Everything would be like Memento, that movie, or the Korsakoff syndrome. You wouldn't learn anything from anybody because everything would be different. So it wouldn't matter. So it wouldn't matter what you did because you'd have no idea what you're doing. That, of course, is nonsense. So the CANS comes at it, TCOM comes at it from a mass customization perspective. So you have these common themes. That's the item of your version of the CANS. But if you look at it, if you do the math, there are more possible combinations of presentations on the CANS than there are human beings who have ever walked the face of the earth. So you can have it fully individualized if you want, but you also have these common themes that guide you into what do you need to do to be helpful. So, and the truth of the matter is there aren't 20 quadrillion different presentations, right? There tend to be clusters. So next slide, please. So, I'm not going to get into this in detail, but I mentioned that managing services was corrupting. It does create this focus on access to care. The fact that you're a very inclusive state because you're competing with each other to give people access to this town hall. That's access to care. Doesn't matter what happens in the town hall, but at least people have access to it, right? So that's kind of the access. So you see arguments all over the place about that, but it creates this tension that when you do an eligibility kind of document, when you do something that guides decision support around do people get certain kinds of help, it puts people in the system in a conflict of interest position. So what we uniformly find is people in behavioral health tend to overrate things, and people in child welfare tend to underrate things. And there's a reason for that, because in behavioral health, you're only paid if you find a problem, right? And the behavioral health system is actually designed. I'm not saying this is how people work. I'm saying how the system is designed to make people as messed up as you can make them and keep them as messed up as long as you can possibly keep them messed up. That's how the system is actually designed from a business perspective. From a child welfare perspective, if you identify a problem, you have to do something about it, right? And so now you've got a different kind of false incentive. So That's why you have to figure out a way to create that kind of understanding. But the big problem, and if you want to use this approach, a lot of people have problems with caseload management because, caseloads teach everybody that everybody's the same, so people hang on to cases longer because they're less work. And so it creates these bottlenecks in the system sometimes, so you can change that. And the idea is time early is more valuable than time late. So a major concept of TCOM is sometimes you have to slow down before you speed up. If you do a good job getting the story early, it's worth a lot in terms of how effective and efficient you are. So I can tell you stories about that, but I don't know that we have time. So if I can have the next slide, I think we're going to jump. So we're really looking at how do you actually change, how do you actually manage personal change? It is fundamentally different than managing spending time with people. So next slide. So this is the acronym. So it's not, it's intentional. So transformation means it's change. So I don't know if you know this, you probably do. So that the states that do the worst job of they take anybody who makes a hotline call, you're coming into custody, that those states with that incredibly low threshold, those states have the best national outcomes for return to permanency because they're removing kids who don't need to be returned, so it's really easy to get them back, right? And in fact, the states who do the best job of not unnecessarily traumatizing young people by unnecessarily removing them from their families, they have the worst national outcomes for return to permanency because they're only taking on the most challenging cases, right? So that's static indicators, discharge status is not an outcome in a transformational system because it creates these false incentives. Collaboration is fundamental because that's actually the only way you can manage complexity. So there's child welfare is like the most complex system in the world. And the only way to manage complexity is either through a hierarchical solution or a collaborative solution. And I guarantee you a hierarchical solution, although we try to use it and judges try to use it, it doesn't work very well. So where a hierarchical solution works really well is in the military. So if you've ever wondered why soldiers from the point of enlistment pretty much are taught to follow orders, that's so that they stay alive in a battle, because the battle is organized from a central location, right? It's centrally located, and so if people follow orders, they're not going to put themselves in a position where they get killed by friendly fire. So collaboration, so that doesn't work if you have more than a single line of authority. I guarantee you in any public sector, there are multiple lines of authority, so you can never have a hierarchical solution. So if the state decides this is how you're going to do it and holds people in compliance, that's not going to work, right? So collaboration is the strategy. So that's actually person-centered care on steroids. So in TCOM, you think about every process as collaborative. My sense of Colorado is you all are already really collaborative, which is great. Outcomes it's relevant to your transformational goals, and management's the hard part. That's walking it into the system. It's easy to get trained in the cans. It's easy to get certified in the cans. As the other folks can testify, it's harder to actually walk the walk and actually use information about people's stories to guide decision-making in the system. Next slide. So I'm not going to spend a lot of time on this. This does not come from a Western culture perspective. This actually comes from Inuit perspective, which, by the way, is exactly the same, although it seldom gets credit. It's the same cultural frame of wraparound. So wraparound was John Vandenberg went up to Alaska, and he was asked by, working for the state, he was asked by the state to help them figure out better serving the Inuit communities. So he went in and hung out. He lived in the Inuit communities for a while and basically asked them how to do it. And so they described it. So that has some significant implications for how you think about this stuff. But also if you have tribal communities, I think you'll find they embrace this rather quickly because it actually comes from a more traditional cultural perspective. Next slide, please.
John, do you want to go into the TCOM, or should we jump into the community?
I think we should jump. I think we want to time. So, of course, I want to go into everything in detail, but I don't think people want to spend 6 hours on this. So,
okay, why don't you end with this slide?
Why don't you go ahead? Oh, should I talk about this? Do you want me to talk about it? Or you
Yeah,
want to?
just go ahead and end with this slide, and then I'll pick up the next.
Okay, so when we think about collaboration with children, that's really a child-family team, right? That's collaboration at that level. But you need to take that up a level if you're actually going to create cross-sectoral integration. It's not much different, to be honest with you. And the one thing that's key to collaboration is there has to be a common vision. There has to be a common purpose so that everybody can win. And so we think that the common purpose in a child-family team is that child and family. But the common purpose at a cross-sectoral integration is that those children and families. Because the one thing that everybody in the state of Colorado has in common, regardless of what sector you work in, is you got into your work in the first place to help people, help young people in our case. You know, whether you're coming at it from a justice perspective, child welfare perspective, or a behavioral health perspective, you're there to help people. So if we keep the focus on that purpose, you have the ability to build cross-sectoral collaboration. Because it's not about the money, it's not about who's in charge, it's not about power, it's about how do we work together on behalf of our children and families in Colorado. And you also need a common language so that you're talking the same talk. If you've ever done some cross-sectoral work, which I'm sure all of you have, you know that each sector has their own language. You know, so and that's not particularly helpful when you're trying to work together. So CANS is designed to be that common language. So it's all yours, Dr. Fernando.
All right. So the concept of TCOM is not just fun for John to talk about. It actually gets operationalized in the way that the CANS has been structured and the way that the CANS is used. And so the title of the slide, Person-Centered Care Requires New Metrics, Communimetrics. This is what underlies the CANS, the communimetric theory. And you can see what some of the aspects of communimetrics is about on the slide, but I'm going to try to explain it in a different way using some pictures, okay? So most of our tools right now are expert perspective tools. So here's our client in the middle of the orange circle and his family, and here are his records, and here are our experts who do various things, interviews, talk to people, read records, to understand who this client is or who this child is. And they complete tools, various kinds of measurement tools that reflect their perspective on who this young person is. Okay, so we're very familiar with that. We have those tools in behavioral health for sure. We have them in child welfare also. The CANS is a little different. This is not a COVID contract tracing slide. This shows how the CANS brings together different perspectives. Whoops, different perspectives. So here's our young person that we're focused our assessment on. There are his parents, the professionals, and this is a group of other professionals, formal supports and informal supports, to use some wraparound language, that if we have access to all these perspectives, we want them represented in the CANS. So the CANS brings together the perspectives. We talk to create meaning together, and then we're able to rate the item to understand where supports for a young person or the family is most beneficial to them and where their strengths could be. So that's the purpose of the CANS. Bringing together multiple perspectives, giving voice and to the young person and the family is really helpful in a teaming environment. So the CANS really enhances and supports teaming. And in child welfare, we're familiar with child and family teams. In behavioral health, we're familiar with multidisciplinary teams, because what the CANS does, it helps to summarize and organize all that information into a way where we can all speak the same language, including the young people and the families, right? It integrates the story. So the CANS is about a young person, but it integrates the context of their family into the young person's story. It helps all of us, the family, the treating professionals, and all the other people involved, have a shared understanding of that young person's stories, and also gives us a way to have a shared vision of how we're going to move forward to identify goals and how we're going to achieve those goals. And the nice thing about the CANs is it also helps us support change management, not just of what's happening with this young person and their family, which is primary, but we can use the same information about many children and their families to help us understand how to make our programs better and how to make our systems better. The tool is based on understanding 6 key principles. Half of the principles come from information science that help us understand how we use information, and the other half of the principles come from how do we create a shared vision and maintain a shared vision approach to our work. The second principle is probably the most interesting to all of you at this particular moment, and that is the action levels. So the CANs uses 0, 1, 2, 3 as the action levels. And unlike other tools that we have in child welfare, behavioral health, action levels aren't just about acuity. It's not just about status. It's also about impact. The impact of a need on a young person and the impact on a strength. So you can see the different action levels here. I'm not going to go through them because of time, but you can see the 2s and 3s we call actionable items. These are the areas where it's indicated that if a need is rated a 2 or 3, that support could be beneficial. It's either because a need is interfering with the young person's functioning or is dangerous or disabling. And you can see from a, is it significantly different clinically from each other? These action levels are significantly different from each other. So going from a 3 to a 2 isn't arbitrary. It's pretty clear what the difference is between those. On the strength side, you can see that the 2s and 3s are about building strengths or developing strengths in young people. We don't think that young people don't have strengths. We want to say it's a 3 that there's no strength identified right now, because strengths in and of themselves require opportunities for them to be developed, and some young people may not have the same opportunities as others. So we're looking at 2s and 3s when we're trying to develop plans. With the strengths, we can also count on using the 0s and 1s, those useful strengths and centerpiece strengths, so that we can engage young people and the families in their own care, and by empowering them, by accessing their strengths, we're able to do that as part of the planning process. This is an example of what the planning process could look like. Once the CANs is completed, we could develop a report that identifies the actionable items. So in the box in the middle there, you see here are the areas of focus that we could easily use to build a plan and talk about in a teaming environment, so that we can make sure we're on the same page. And so from here, what we do is we identify, as it says here in the corner, target needs that we're going to address, and the effect of addressing those target needs will be the anticipated outcomes. The CANs isn't just useful at assessment or at planning. It's also useful in monitoring and adapting the plan to make sure that our plans are always optimized. It's also essential that we use the CANs in coordinating care. And this is where cross-system use of the tool is really important. Because again, if we're speaking the same language, we can identify similar needs and identify similar goals, and all work together to coordinating our plans so that they're in line with each other, aligned with each other, rather than potentially clashing with each other. John, I don't know if you want to spend the last 3 minutes talking about this. Are you there, John? Are you muted? So let me just end our chat. I don't know where John went. to talk about, this is the TCOM grid of tactics. So if we're thinking about the levels of our system, so those are the columns in this table, families and youth, the program and the system. We can use the information from the CANs, person-centered information, to help us with things like decision support, outcomes management, and quality improvement across each of the levels of the system, which is fairly unusual for a tool to be used in this way. So I think I'm going to stop here unless John can pop back on with his audio and if he wants to say anything in closing.
Well, we do have one question, April, and
Sure.
You're more than capable of answering that, is for sure. And this one came just before the town hall. So how does the CANs, or does the CANs, address the needs of children with intellectual or developmental disabilities or autism?
Interesting question. We do have specific versions of the CANs for folks with intellectual disabilities, and we have a specific version for autism spectrum disorder issues. So we do have two special versions to make sure that we're addressing the specific needs of those populations.
You would have to decide, though, and what you'd end up doing, what people do is they take the unique items from those versions and make them modules. So I think, correct me if I'm wrong, April, the Colorado version currently has a single item that sort of could be a trigger. Yes. And then if you wanted to know more about it, so if it's a 0, you say there's no concern, so we move on. And if it's a 1, 2, or 3, well, you'd say, oh, well, we need to know more about it. You know, is this autism spectrum, or is this a different developmental challenge? Or, you know, how are they? They have agitation, or they have restricted interest, those kind of things.
And I'll take one more here. It looks like before we get too far, but how does the CANs address the level of care?
John, why don't you do that one?
Sure. So we use algorithms. So algorithms are used around the country. They're Boolean. So there's a couple of problems with traditional uses of level care models. Number one is people use prior service receipt. That's where systematic bias lives, because use of prior service receipt to make level of care decisions makes the assumption that prior service receipt was completely clinically rational, which of course we know is not true because other factors influence it. The other problem with traditional ways of doing level of care is that they'll create a measure with a score and cutoffs, but that's a real problem at the margins. So even if you norm a measure, it's still a problem because let's take IQ. So you can make a decision at 70, right? So if it's below 70, it's one thing, and if it's above 70, it's something. Here's the problem. You're going to have a tough time legally because there's no evidence that a child with an IQ of 69 is actually different than an IQ of 71. And to make a decision based on that is arbitrary. And so it's a problem. So we use patterns of actual needs. There are complexity metrics. There's been algorithms that have been running over level of care for almost 15 years at this point. It's had dramatic impact on improving the effectiveness of systems. So. And we're happy to, that's a whole nother long discussion, so I apologize. My kids always say, Dad, give us the short answer. Not possible.
No, I appreciate that. And we have a couple other questions. Just honestly, keep putting them in chat, and we'll make sure that we come back and circle to those. I just want to make sure that we get through the full presentation. So I want to welcome Kit Thompson. And Kit, can you discuss, again, like how we are going to use the CANs and how are we using the CANs in Colorado right now?
Sure. Well, as most of the people on the townhome know, we're engaging in the process leading up to the Family First Prevention Services Act and going live. And as part of that act, there is a requirement that in order for a child or youth to be placed in a QRTP, or the Qualified Residential Treatment Program, the new kind of RCCF as it used to be here, that a qualified individual or an independent assessor assess the strengths and needs of the child using a validated functional assessment tool. And so in Colorado, we chose, as many other states did, the CANS as that assessment tool. Because we, for all the reasons that John and April elucidated, it's a well-used tool across the country in child welfare, and has been, is really designed for this kind of a way of looking at a child and family's needs and strengths. So, so what we've been doing in our statewide implementation team, there has been an assessment work group that spun out of that team to really look at, initially to decide which assessment instrument we wanted to use, but then to really lay out the whole process of how this is going to go in Colorado and what the process is going to be, much of which is laid out in the Act, but we needed to Coloradoize it, and how we were really going to do it here. So the team that Matt and Andrew and I have been co-leading has been working on all the different aspects that we need to nail down to make this happen, including who are going to be the independent assessors, where is that going to live, how is the information for the CANS going to be gathered, what do counties need to provide to the independent assessors along the way, and how are things like the child and family team going to work? What is the county's role in helping to organize different pieces of this? There's another requirement in the Act about this then gets translated, the recommendations out of the CANS, the assessment, and the child and family team need to go to the court, and what is that going to look like? So we've been working on all of that, and we've been also developing some flow charts and some checklists that can go to counties so that everybody knows what their role is and what the timeframes are. The Act says that the assessment needs to be done no longer than 30 days within the placement within the QRTP. And we have decided as a state that we want that to be sooner than that, that we don't want a kid just sitting for 30 days in a facility and then we decide that this is or is not the correct level of care for them. And so our recommendation is whenever possible that this assessment is done prior to the placement in that level of care. And if it can't because of some kind of emergency placement situation, that it be done within 15 days. So we've been designing all those, how that will all play out over time. But that's what we're looking at in Colorado. And while we have been focusing primarily on the development of the process around the QRTP, there have been a lot of discussions, not only in this committee, but in others, about how we want to be able to use the CANS more comprehensively for all kinds of levels of care and services, and for the treatment planning for our children, youth, and families. So, that's a quick thumbnail of what we're doing in Colorado. I'm glad to answer any questions that people might have going forward.
Nice, Kit. I think there's one more that I think that makes sense. So it's from Lynette over in Mesa. So who's expected to complete the CANS? And does it need to be a clinician? So how does that, a little bit of that processy piece here?
Yeah, okay. So what we've decided is that there are going to be it does need to be a clinician. And that it's going to rest in our ASOs, or the administrative service organizations, that they're going to be contracted by OBH to do that service for us. So as any of you who know the ASOs, they're the ones who do the emergency services currently in our state, and they are located at locations all throughout the state. So I know there was a lot of concern early on about how are the rural and frontier counties or the mountain counties going to get what they need. And there is a whole network already set up to be able to do that.
Outstanding. Thank you. And I see Ashley, there's a couple other questions coming in, and again, we'll try and get to those as we go. Andrew, you want to wrap us up here with all the things that we're looking forward to potentially doing with the cans?
Yeah, sure. So again, just for the people who maybe arrived after introductions, I'm Andrew Gabor. I'm the Director of Child, Youth, and Family Behavioral Health for the Colorado Office of Behavioral Health. I also wanted to just mention that, I think a lot of our thoughts are guided towards Grand, Larimer, Boulder, and San Juan counties. So just wanted to do a shout out to them. And I think being in the Front Range, a lot of our roots are in the mountains. So we're all definitely thinking of you all right now. So that aside, I do get to talk a little bit about the magic wand of what the cans can possibly do for the state of Colorado. I think to kind of clearly delineate how we got here as well is that the cans is not new by any stretch of the imagination. I know when I first started the state back in 2012, one of my coworkers gave me this report that the Rays had done, or not the Rays, sorry, the residential providers had done a research regarding the cans. And so that was one of the first reports I read when I started at OBH. So it's been around. We do have some early adopters. Family First is definitely the largest early adopter of the cans. We can also include the COACT grant, which is our multi-million-dollar OBH system of care grant for high fidelity wraparound. It's going on its 10th year at this point. We have the Children Youth Mental Health Treatment Act. We have the CHIRP waiver. And those are all specific programs and actually leading counties as well that have all used the cans. For a number of years, there was a debate within Colorado regarding, okay, we're going to use the cans, we're going to use the tops, what else are we going to use, what's out there? There's been a lot of thoughtful engagement around this, but I think it's all coalescing around the cans for all the reasons that everyone has talked about already. Now, what does the future look like in Colorado? I think you all have a part to play in deciding that. Nothing has been set in stone. We have momentum, certainly, but there's always room for improvement. I think improving behavioral health and improving the lives of our citizens is an iterative process, right? But I really strongly feel that Colorado is on the cusp of major behavioral health reform. Just a few weeks ago, Governor Polis was presented the behavioral health blueprint that the Behavioral Health Task Force presented to him, and that has some pretty large changes that it's recommending for behavioral health. That includes a behavioral health administration, includes the recommendation of a single entry point, and also intensive care coordination. It also includes a lot of items regarding crisis services. Kit talked about the ASOs. The ASOs are the administrative service organizations are they're like the Rays for OBH. If you're familiar with BH or for Medicaid Rays deal with Medicaid, right? Those guys. The ASOs deal with us. And part of their role with Family First will be managing the network of clinicians to do the cans for Family First, okay? They also manage CYMHTA now for the most part, and so there's some mutual resource management and cost reduction and sharing of resources, especially in rural and frontier communities that have a limited workforce, that we can work smarter, not harder, regarding our programs. Now, regarding the Behavioral Health Task Force and administration, and OBH just released our population needs assessment that parallels the blueprint as well. Talks about this stuff to a pretty large extent. If you haven't seen that, I highly recommend you go to the CDHS website, look up OBH, and pull down the population needs study. But every activity that stakeholders have requested can be affected by the cans in a positive way if it's used the right way. Now, how it's used the right way, again, it takes a lot of thought. We have a work group that is affiliated with Family First, but it's also kind of a standalone meeting where we have members of OBH, we have healthcare policy and financing, we have counties, we have RAIs, ASOs, child welfare, families that attend to really help design how the cans can be used in Colorado. Right? What kind of cans do we want to use? Because there's many different types. It's almost, I'm sure Dr. Lyons has a better understanding of it than I do, but like, it's like an erector set. You can kind of change things out a little bit depending to meet your needs, right? So what does that look like if we want to use it broadly? Do we want to use the same cans for CHIRP as we want to use for the Children and Youth Mental Health Treatment Act or Family First and so on and so forth? And can we use a data system that brings that all together? And the idea is that, yes, we can, and that the Office of Behavioral Health is designing that. Right now, we've and the data system is much bigger than just the cans. It's a very large data system for all publicly funded behavioral health. That's the goal. So that, one, the data isn't just spliced and separated in multiple different places. And also, the biggest thing is that data is usable. What I have personally heard from families and children and youth is that they get really tired of telling their story over and over and over again just to receive one service. And now they want two services. Well, let's start all over again, right? Let's have the system communicate. And I know we've been working on that for a long time. The cans can move that as well. Where the cans is not is in itself, it is not a replacement for a full intake, a biopsychosocial intake that you would do at a mental health center or mental health clinic anyway. It's a tool to be used in conjunction with that. Just like if you were a caseworker and you're in a county and you want to use the cans, you wouldn't stop doing your intake. You would do your intake, do your state required stuff anyway, and use the cans to really help consolidate that information. And if we can put that in a spot that's usable for the family and the consumer, it's usable for the clinician or caseworker, it is usable for the treatment team, and it's usable for the supervisors and the agency, the region, and the state. And if we can do that, like, why shouldn't we do that? That sounds great, right? So that's that magic wand of like, hey, if you could fix this system, what kind of a data system would you want? Well, I want a data system that works for everybody, right? And that's what we're trying to design with the cans. And it's a slow and iterative process. And when we have those early adopters, and we're learning a lot from them, and we will continue to learn a lot from them. So I think with the Behavioral Health Administration, with the rollout of Family First, conversations like this are our first steps, but we need to continue the conversation and make sure that it works for every corner of the state and that we're responsive to people's needs, while also making sure that we are very thoughtful on the concerns, because the concerns are palpable. When we start talking about data, and if I'm a family member and hearing that, oh, what I tell you is also going to be shared with all these other people, well, that's concerning. Like I have a right to like say, no, this person can't get that information. So there's lots of stuff we need to work out. Funding we need to work out with healthcare policy and financing. Who pays for the counties? HCPF, OBH, like who does that? Commercial insurance, they have a part to play. And so there's many, many different aspects, but I can say that I have a huge hope that the cans can be broadened beyond just the early adopters and the people that we have. OBH, we've trained, I think over 100 train the trainers at this point in Colorado specifically. And so we're building up that workforce to really hit the ground running for larger implementation. So I'm going to stop. Matt, if you have questions. Or anyone else want to add?
I happen to notice Dr. Lyons nodding and even at times smiling with some of the things you said. So I just wanted to provide him an opportunity to react to some of the things that you said and how we're looking at maybe moving this forward in the future.
Well, Andrew and Kit kind of said what I would say, right? I thought you captured the essence of TCOM really well. So thank you. So you obviously been doing due diligence, and you guys have been working pretty hard to try and figure this all out, and it isn't easy. I mean, but it's worth it once you do it. So.
Absolutely. I've been paying attention to our meetings. Trying to learn.
So we have 8 minutes left. We have 176 people on here. I just want to make sure that we have any questions that we have for Dr. Lyons or Dr. Fernando. Not that I want to ignore Kit or Andrew, but we have their time more frequently available to us. So I do see one Joni just put in chat. So there is a lot of subjective language in the CANs that can be defined very differently depending on what system you are in, which will obviously change the scoring depending on who does it. In each entity that is involved that has a different agenda or goal, will there be training to the entities outside of child welfare to clearly define the wording and align our goals?
That's a brilliant question, and it's a really fundamental to why we have so many problems cross-sectorally. Because, Joni, you're absolutely right. That's actually not about the CANs, right? That's about the nature of our cross-systems challenges. And the CANs is proudly and intentionally subjective. And if you think that's a problem, we should talk about it because, I don't know, maybe you learn the same thing I learned in graduate school, that subjective means unreliable. That's not true. Subjective means judgment is involved. Judgment is actually required for you to work. I mean, people have to think. I mean, you do have to think if you're going to be effective. And so the CANs puts a structure for how you think and how you communicate to each other about how you're thinking, but it will reveal that different people think differently. And that's when you have the opportunities to bring people together to say, okay, let's try and understand how we're each thinking about this and come to a common understanding of that, because that's actually how you fix the system. You can't just say, well, let's get these counts of stuff, right? So people like counts of stuff because it's subjective, but frankly, it ends up with bullshit. It ends up with information that you actually can't, excuse my language, but you can't really use it to make good decisions because you have to contextualize things. You can't be culturally sensitive and not be subjective. You can't be person and environment and not be subjective. You have to be subjective. That's a good thing. And so you just want to make sure you're consensus-based and you're transparent. You don't make judgments without people's participation, and you don't make judgments that don't matter, right? That you're actually being open and transparent about the judgments you're making, and you're bringing people together to make the decisions, the judgments together, and that's the key to it. I don't know if you wanted to add something, April or Andrew or Kit.
No, you did a nice job.
Then we have time for one more, and I just want to try and get to them in order. Nice. So I guess there's a question, and maybe it's for Andrew, or maybe it's for Dr. Lyons. So I'm going to get to Tracy's question. So it was previously stated that the mental health system was designed to keep people for as long as possible, with OBH being the assessor. How is that any different? What makes them the expert in getting the best placement for the kids?
Good question.
Yeah, I can jump in. So first of all, in terms of the length of time that someone is in placement, the independent assessment process is done with that. The OBH is just the gatekeepers to see if someone qualifies or may qualify for residential services through a QRTP. One thing that's different is that the independent assessor does not get paid depending on the outcome of the assessment. They cannot be affiliated with a county. They cannot be affiliated with a QRTP or any other provider that is interacting with that child. And so if they say yes or no, there's no financial gain for them. And part of that is we want to also make sure that they're licensed, that they're not just master's level, to make sure there's that additional level of oversight, professionalism, experience, things like that. And then lastly, OBH will be reviewing each one of those assessments to make sure that there is no bias and that they're like, if they say, hey, this person doesn't need a QRTP, but they really need to go to my mental health center. It's like, no, you can't say that. We have a very similar process with what's called OBRA-PASAR, which oversees people entering nursing homes, which that process was actually developed to prevent nursing homes from becoming IMDs. And then a year and a half ago, we started thinking, well, can that kind of flow work for the independent assessment for Family First as well? So there is some levers and making sure that there is no financial gain for anyone in particular.
I might take a sort of a conceptual crack at that. that's a great answer, Andrew. The CANS doesn't really fix any problems that you have. The CANS provides a platform to help you fix problems that you have, right? It'll identify problems, it'll surface things that are issues, and it gives you a way, a mechanism to say, because it's been our experience that if you make your decisions based on the best interest of the people you serve, you have a much better system. And the only way you can actually make your decisions based on the best interests of people served is if you have a way of talking to each other about the best interests of people served. So that's all this really is. It doesn't solve any problems. It doesn't suddenly make it a transformational system, but it gives you a information structure that allows you to do and that's what Andrew and Kit were talking about, the hard work of actually beginning to move in the direction of being successful in that. Oh, there's a question for you, April, about cultural factors. You want to take that one on? Do you see it in the chat? Does this assessment take into account cultural factors, or is it something the clinician should bring into the interview? Where could this fit into the tool? Great question.
It is a good question, and the answer is yes and yes. So the clinician is required to bring it in with them to the interview to understand their own unconscious biases, to understand when they need support and help, and working with folks that they're not familiar with, and also coming from a culturally humble place to try to understand who people are and capture their story as best they can in the CANS. We also have cultural factors or cultural needs items that can hone in on specific cultural needs that clients might have as well. So we have, both are important.
There's also the, what is it, the fifth key characteristic? Did you talk about that?
Yes.
Okay.
Yes, one of the principles is that we have to take culture into account before we rate items. So it's about really understanding who people are, what their behaviors mean from a cultural perspective, making sure we understand all the different cultural identities that people hold, because otherwise we don't really understand who people are. So there is a bit of a training issue around how you approach your discovery process and getting to know people, and making sure that people understand how to do culturally humble clinical interviews.
Yeah, the real tension here is the tension between being culturally sensitive and having a common language. So if you don't allow people to you have to have a common language, and a common language needs to be culturally neutral. But you also have to be at the same time culturally sensitive. So that's how we've designed that characteristic. It allows you to be culturally sensitive as you talk, but then you need to filter that into the common language framework by saying, okay, I understand their action needs in terms of their cultural context. So you can accomplish both with that model. That's the idea behind it. But there's a learning curve, as April says.
Outstanding. So we are 1 minute over time. I think that is just fine. I put in the chat my email address for folks, so I know there's additional questions. I know as we answer questions, additional questions arise. As per process, feel free to email me, and I will make sure that we get those answers either through Andrew or our work group, or through Kit, or if we need to send them off to Drs. Lyons and Fernando, they're able to help us out. So I do want to say, again, thank you to all 4 of our presenters today. I really appreciate you guys taking the time to be here. I, per usual, learn a ton of stuff at these. So again, thank you so much. And for everybody else, thank you all for taking the time. I do believe this was the highest attended town hall, not that I'm keeping score. But 204 people were here. So it's wonderful to see you and connect.
I'd just like to say thank you for everybody who attended, and thank you for what you do for others, because it's the work of angels. So thank you, because it's people like you that make the world a little bit better place. So thank you for that.
Thank you all. Have a fantastic day.
Take care.